We went to 30 this forward. Is there? They. Yes. Yeah. We can. They. All right, guys, so I think we'll pull back together. If you guys want to find your seats, and we'll get underway. So it's a little small, but it is in your manual as far as our course agenda for today. So between now and about just shy of 11, we're going to go through the order flow chart that's within your manual. And then we'll go through, there's 3 steps that we kind of outlined within the assessment process. First is going to be our kind of the subjective examination, the physical exam, and then the physical exam components, where we'll go into our first demonstration and then actual breakouts there within. So I think if if we were going on a treasure hunt, we would want to know what we're seeking, correct? Right? We need to know what we have to begin with the end in mind, as they say. So if that's the case, your end goal within your assessment, I would, and you can tell me otherwise, yes, you're going to identify your impairments along the way, but you're seeking what is the terminology, your physical therapy diagnosis. Is everyone else in agreement? People have other things that they're seeking when they're doing their assessment besides for impairments and their PT diagnosis. Okay. So we have a lot of years of experience. I would say probably, I don't know, a century and a half if we aggregated it all together. My question to you, feel free to speak up, is what is your physical therapy diagnosis? Yeah, can you give an example for the shoulder?
The shoulder blades are a little lower, you're not uploaded enough, like upper rotated enough, like 50 degrees with 100 degrees shoulder.
Very specific example, Manling. Thank you. Okay, so what is the purpose of diagnosis? Is it being able to label something such that you can communicate it to somebody else, and that somebody else can determine prognosis and treatment determinants or interventions that would help with that said condition? So say it once more, Menling. What would, not the explanation that you gave, just the title of your PT diagnosis?
In the scapular rotation with shoulder reduction.
Okay. Great. If a show of hands, if a colleague came to you and said, "This is the diagnosis of this patient, I need you to see them." They may give you some other details, but the diagnosis in and of itself, would you know what to do? Show of hands. Yes. We have 3 hands. We have some other nods. Okay, great. Anybody not know what to do with that? And or do people have other diagnoses that they would define as a physical therapy diagnosis and or definition, an example similar to what Manning offered? No? Okay. Maybe everybody here uses the MSI approach then? Show of hands of yes. Oh, wait.
Well, I was gonna say, like, say for example, because it seems like we're, as a profession, we're moving away from like terminology like frozen shoulder, right, or adhesive capsulitis. So are you saying like so perhaps just describe the impairment like capsular stiffness, or describing what we find as opposed to just kind of, if we kind of have an idea at least on their presentation of what it is, instead of just saying what it is. that kind of.
Yeah, it's really more from a curiosity standpoint. I'm not seeking anything in particular. I'm just interested as to how, us as a profession will use, the 20 people here as a surrogate example of like, how do we define like our diagnoses? Because that's what, if we don't know what we're looking for, we don't know how to define it, and it's somewhat vague, it's going to be very difficult for us to like pinpoint that.
Yeah, and like, for example, like if, if you see a patient, from calling and it just says shoulder pain, right?
Yeah,
Yeah.
that's problematic. So it's something that I've struggled with, and maybe you have as well. I don't know. But the proposed framework for diagnosis that I'm going to offer, I feel like the physical therapy, I've talked to a lot of people about this, and I've settled on these four components to make up what is physical therapy diagnosis. The first is the pathoanatomical tissue pathobiology pain mechanisms, the tissue source. So despite the push in our profession to drift away from that, I think that that's an important communicating point, not only to the patient, but also to the medical community at large, because everybody else in the medical community does talk about like, what is the issue? Is it a rotator cuff tear? Is it a bursitis? Is it a tenosynovitis in my long head of my biceps? And so on, right? And so I would say that is the first element of a communicative point. The second is, so what is the tissue source? What is the tissue stress that is pissing that said tissue off? What are the movement faults, which was offered by the MSI example? And then what is the ICF classification? Because a lot of our clinical practice guidelines are moving us towards these large buckets, which are helpful because they also help to guide communication and prognosis and thus interventions. So, when this is the way that I frame the PT diagnosis would be, if we were talking about the exemplar of insufficient upward rotation and posterior tilting, I would start with, I'll give an example that I would say it would be my primary, they've moved away from like shoulder impingement, but it's like shoulder impingement syndrome, right? Because it's a compilation of things. Specifically, my tissue source is going to be the articular surface of my supraspinatus tendon and or the bursa, depending on how inflamed or chemically inflamed they are, right? Are they presenting more mechanical where they go out and then it's off? Or is it like at rest, they're having persistent pain, would tell me if it's more inflammatory within the bursa versus not, and what their subjective would be. My tissue stress would be compression. My MSI diagnosis we've already described is like what's actually causing that compression is insufficient posterior tilting or upper rotation. And my ICF classification would probably be, depending on the irritability of it, I could either classify them into my pain category, because that's one within clinical practice guidelines, or it would be our motor coordination, right? Where we actually have to do retraining of the scapula to then allow for better subacromial space and allowing for better overhead motion, for instance. And obviously there's impairments listed there within. And for clarification, within that is the ICF classification. It doesn't suggest that they don't have strength issues and they don't have power issues and their muscular endurance of their shoulder is somewhat compromised. No, I label that as what is their primary at this moment upon presentation. Is it pain generative? Is it more motor coordination? And so on. And again, there's certainly instances where you could have all the same first three, and then a different ICF classification depending on what your physical exam shows. So, and I've written it out in your manual, and I've provided references for what has led me to coming up with that four-tiered system of what is a physical therapy diagnosis. Again, for me, it's been the most comprehensive, the most concrete. It checks all my boxes, from communication to the patient, to the medical community, the third-party payers, and then it also allows for guidance of prognosis, determination of proper classification, and then intervention determinants. So I'm going to be using that framework as we move forward, that we will essentially be striving for that. It's just for further reiteration, if we broke out the MSI, and thank you for Shirley Sarman for all her great work within our profession, right? She has identified at least 9 specific movement coordinations, which would make up that third element of my PT diagnosis. And rightfully so, Ming had spoken about the insufficient scapular rotation. And then our shoulder ICF classifications would fall under one of the 6: pain dominant, mobility deficits, motor coordination, muscle strength or power, other, meaning it may be not captured by the other 5, and then related cognitive and or affective tendencies, which can accompany any one of the other ones. And so when you look at the clinical practice guidelines, regardless of the body region in question, those are the consistent buckets that they come out with. So let's talk about high level overview in regards to the shoulder. Get that thing out of there. All right, so shoulder evaluation. So you have your decision-making triage. The first determinant is this person appropriate for physical therapy, right? So this is, we're not going to go too far in depth with your medical management and your screening out. It's going to be your red flags, right? Or moderate to high psychosocial risk. Maybe it's like yellow flags or other social determinants of health. And or are they more in a self-care management model where you can run, they only need really physical therapy services. You don't need to get or lean on other healthcare professionals and get them involved. And that all kind of starts and plays into your subjective examination. Then is your hypothesis generation. I've lumped these into kind of 4 major categories because of like the pain, like what type of pain are they experiencing? Is it somatic? Is it nociplastic? Is it neuropathic? Or is it nociceptive? Right? For me, I'm always hopeful that it's just nociceptive, and these other elements it's relatively simplistic, but it's usually not simple, right? It's usually a combination of multiple, right? But again, trying to make what is complex simple, what is the predominant, and and how can that influence your interventions? There within, you can break it down into your pathoanatomical tissue sources, and I've labeled almost 10 of them. It could be referred pain, it could be your pain dominant, you could be your bone, joint, ligament complex, subacromial origin, tendon, muscle, or other. Your physical exam decision-making would say, really, there's 2 questions. You've conducted your subjective, you've done your chart review, and then before that take a momentary pause between your subjective and your physical exam. Probably a lot of us do this already implicitly if we've been practicing for years. Others, maybe we're still like thinking this through explicitly. And I know at times I've had to written it out as far as like what my next move or step is going to be as I'm planning the physical exam. Is it going to be full or limited? So this is going to be based off their irritability and their severity. And then it's also going to be determining, do I need to have a neurological examination or not? So my clinical practice has swung in multiple extremes coming out of school. I did an upper quarter screen on everybody I saw that had pain above the navel, right? Very quickly, the mentors that I had in my residencies, they asked me, what are you doing? And I was like, I'm doing what I was told, right? But it really should be much more algorithmic and streamlined for that. So we within our residency right now, I'm big on talking about that you shouldn't have to be guessing on your neurological examination. If any one of these 7 things apply, then yes, a neuro screen needs to be conducted. And it's not like, maybe I'll just do myotomes or maybe I'll do my dermatomes. No, if you're going to do it and do it all the way through. Right. And so if you have symptoms rating distal to the chromium, you have weakness, paralysis, or any paresthesias or anesthesias that they're talking about, bilateral upper extremity symptoms, current loss of dexterity, they complain of dropping items, not because of weakness, but they can't really otherwise explain it. Sudden onset of severe cervical spine symptoms, previous history of referred symptoms, gait disturbances, or stocking glove distribution would determine us to require on day one doing a neuro screen. And then what the final determinant is like, what other body regions beyond just the glenohumeral joint should I incorporate? Again, I was taught early on is that, yeah, you want to check the joint above and below. Yeah, how thoroughly and is that a day one necessity? It depends, right? I'm not always going to do a thoracic screening or cervical spine assessment on every patient, and the current evidence would suggest as much. That one determinant of whether I talked about full or limited physical examination, I use, so it's from Kelly 2009, where they talked about I think it was one of the early clinical practice guidelines for the stiff shoulder. They talked about describing or stratifying someone's severity and irritability based off 6 different determinants. What is their pain level? Do they have night pain and or resting pain? Disability of range of motion, disability of their functional outcome measure, and do they have pain with range of motion? Is it at the end range? Is it in the mid range? What is their active versus passive, and what is the duration of symptoms? And so in the algorithm that I'm running is that I have 3 standard operating procedures. I have my acute shoulder assessment. I have my standard orthopedic assessment, which will for the most part focused on today, because then you can always stratify that based into your other, and then your other higher level or lower level, and then your higher level, where I have someone who comes in and they're like, yeah, it's not until I've been doing my kipping pull-ups for at least 2 sets with my CrossFit that I actually have pain in my shoulder. I'm like, well, that's going to be kind of hard pain to define, right? Versus the individual who's like, oh, right. They're like, it's immediate, right? And so as they're telling me their story, I'm trying to, which button do I want to hit play on? Is it going to be my acute, my orthopedic, or my higher level? And then as they're telling me their story, I'm trying, am I thinking contractile tissue? Am I thinking bone? What was the mechanism of injury, right? All these things are running through our minds simultaneously. And so that's kind of how I think through it. I'm sure we all have our unique means, but if they're high severity, I'm going to run my acute. If they're moderate to low irritability, I'm going to do my standard. If they're low irritability and moderate level of activity that they're coming in with, depending on what their life endeavors entail, I may or may not do my standard orthopedic assessment or standard operating procedure is going to be run, and I may actually throw on some physical performance tests if I need further impairment determination for where we need to start. And then if they're low irritability, high level, that's where I definitely incorporate my physical performance tests within my evaluation. And that's how I kind of think through that determination. I gave you, I think it's kind of a nice schematic of determining whether this is a mechanical, like on-off pain symptomatology, or a chemical and inflammatory one. But really where we're going to spend the majority of our session is going to be in these steps 1, 2, and 3 that I alluded to. So step 1 is going to be your subjective examination. Relatively explicitly, I've listed off the primary questions that I think should be asked. Certainly, again, there's going to be nuances of how we navigate a conversation with somebody, right? But it's usually more in this kind of dialogue, open-ended question type of format. Yet the terminology is called paralleling, where in the back of your mind, I know all the elements I need to be getting, and I'm just going to have a conversation with you, and I'm going to try and tease out those things as we go, versus I think the more linear approach that is taken early on in careers is that, here are all my questions. I'm just going to run you through these questions and get my answer. Right. But you can, statistically, 87% of the time, the diagnosis comes out within the first 3 to 5 minutes, right? And that's not like my own statistics, right? They've done these statistics where they actually like film sessions within the physical therapy and the orthopedic realm, where that's as quickly as the diagnosis can otherwise be determined based off what the person says. And the more that they say, the better off, and the quicker you can start to make these determining factors. The ones that I do want to kind of focus on here, because I think that they are relevant, and I'll zoom in on it, is because this was a relatively new paper. If I highlight over it, you can see that it was published in 2020, and I think it's also important just to acknowledge that all the references, not only the end notes, but also the references themselves, I've tried to hyperlink. So if you're going through this and you're like, I have no idea where that comes from, and you double click on it, it should take you immediately to your references at the bottom to the hyperlink. Because the annotated bibliography makes up 50 pages, which is over half of the manual that you have in front of you. And then, again, I tried to make it streamlined, yet also simultaneously extensive. So the red flag screening, so you have level of concern. It's on a sliding scale. Again, it's not a dichotomy, right? So do you have no concern? Rarely. At other times, right? You have some concerning features, and whether you need to have an emergency referral or otherwise, does this person belong in your clinic? And so in that determination of red flag screening, again, we won't go thoroughly into this, but enough that the ones that you don't want to miss, right? Fracture, infection, cancer, massive acute rotator cuff tear, avascular necrosis. The one that I'm going to highlight is I thought this was really cool and something that has been helpful for me, because I think that there's 5 implicit questions that every patient comes in with, whether they know it or not, right? The first is, what's going on? Why am I hurting? The second is, what are you going to do for me as a physical therapist? What am I going to do for myself? How long is it going to take? And what is it going to cost me? People, I say cost and people immediately think finances. No. The most precious commodity that people have is their time and their energy. And so I'm going to tell you that, I don't know your insurance policy. I can't tell you, unless it's a cash-based clinic or model, I can't tell you exactly how much it's going to cost. You have to work that up with your third-party payers. I certainly can be helpful in disclosing what our billing looks like. That being said, more importantly, I'm going to ask for your time. I'm going to ask for your energy. This amount of time per day would be my recommendation. However, we make this individualized and customizable to you. But to answer that fourth one of how long is it going to take is prognosis stratification. This is something that we've really emphasized within our residency, within our clinic, because it's hard. If you are a young clinician, you haven't really had exposure, if you're not really familiar on the data analytics or informatics of what is the typical rate of people that have rehabilitation and for their rotator cuff tendinopathy, how long is that going to take? Right? It's somewhat hard. This scoring system allows you to help to stratify that a little bit more effectively. So the duration of their symptoms upon initial eval, was it a gradual onset? The concomitant psychological complaints, which if you don't know what questions to ask for that, you can use a functional outcome measure, right? Kinesiophobia and otherwise. Repetitive movements are painful. Shoulder pain and stratification, again, if you're not the neck pain in the shoulder 0 to 10 and 0 to 18 usually require a little bit of further breakdown. But again, if you just click on the little 25, it will give you what that looks like and how to actually properly stratify it, and the risk of having pain over 6 or 12 weeks beyond how they actually present. Again, we could really talk at length about the subjective examination and what questions to ask, but I just don't think that that's where we want to spend the majority of our time because we are somewhat limited. So I put some helpful reminders. So on average, it takes 92 seconds for patients to explain the problem if not interrupted. Providers are 7 times more likely than patients to interrupt. I agree with that. I'm definitely more likely to interrupt at times. Yep. Accurate history taking will provide 80% of the information required to develop the terminal diagnosis. And then to help you with further stratification as to what they may be coming in with. So we've used what is known as the STAR framework, which is currently taught on the OCS as far as shoulder stratification and diagnosis and classification. I know Lori Mishner, a huge shoulder giant out of USC, was behind that. I forget the other authors, but she was definitely a name that rung out to me. And they talk about rotator cuff syndrome when they lump that in with subacromial pain, instability and or labral pathology, mobility deficits and or adhesive capsulitis, and other. Again, it may seem like an oversimplistic model, but oftentimes taking the complex, making it somewhat simple, allows for better stratification and less paralysis by analysis. And so taking that framework and then breaking out what is our questioning and then what is our physical exam will be the steps in which we go through that. So your step 2 is really physical exam decision making in those moments between your subjective and your objective. And then your physical examination is where we'll start with our demonstration and our breakout. Any thoughts or questions at the moment? I said more of a monologue rather than, more of a dialogue than a monologue, but maybe we'll warm up as we go. So postural assessment. So I think for this, we will take a volunteer. If anyone wants to stand up. Come on up. All right. Are you okay taking your shirt?
Yeah.
All right, great. Why don't you take off your hat and we'll go from there. Any shoulder pain or history that we need to tell of?
Labral rotator cuff repair 20 years ago. And acute shoulder pain. Do some gardening yesterday.
Got it.
Busy weekend. Yeah.
Fair enough. Okay. Perfect subject. Thanks for volunteering. Why don't you put your stuff down and then we'll have, I think maybe the better way to play this is just in the open space on the outside here. I'll just flip this around so we can see. So the first thing that we see within the postural assessment, and for clarity, I do preface that there's a full postural chart and checklist that you can do from multiple different angles and planes of motion. For our intents and purposes today, we're going to focus on hands on hips. And then there's also a wall press test. So I'm going to, sorry, I forget your name. Tree. So I'm going to have you go hands on hips. So when we're first observing, right, you can look at posture and kyphosis of the spine and things of that nature. Is it okay if I put my hands on you?
Yeah.
Right. So one of the most effective ways to determine scapular weaning and or any atrophy and muscle bulk alterations would be in this position. And then you can have them exaggerate it by doing a couple of strategies. One, you actively push into so it pushes in, things become a little bit more apparent, a little bit more medial border leaning on the left versus the right. When we look at the overall gross muscle bulk, which side, if any, seems to be more developed?
He's pushing into it.
He's going like this, yes, yeah. All right, that was in attack, I think, you.
What was your cue on that?
Yeah, it was like this.
Push inward? Okay. Gotcha.
Yeah, and then you bring your shoulders back, or your elbows back just a little bit. Yeah, that can also. All right, so what I see is a little bit more upper trap development here. I would say that there's a little, again, it's a little bit subjective. You don't have good objective means by this. All you're trying to do is determining, like, what is my next step? What are other things I may want to look at? The other one would be doing a wall press. So we're going to have you, I think the closest wall that will be available would be just over here. So we're going to have you go over there and face the window straight. All right. And then Jason, feel free to on this one.
Yeah.
So for this one, you're gonna put your hand on the wall. And then you're gonna just kind of stay upright and then push it against the wall. And so for this one, what we're looking for is the same, kind of similar things, like looking at Nico border comments, inferior angle, like protruding. It's kind of like with the lighting kind of obviously matters, so like from the side too, like you do come from the side where you can see a little bit of the inferior border, like winging, but I wouldn't call it winging, because one kind of like that term of long grass and nerve injuries. But, you know, with that. And so, if some of you guys want to come over here and see this on the side, it's more so, the reason why you're doing this is because you can see whether it activates more of the serratus. And so go ahead and push into the wall. And you can see how it pops up just a little bit more. And so this is something where, in terms of when we go into our intervention later, this is like, we'll take this under consideration. And so the other things you can look at is, does he use upper trap more for this? It's more going into that movement kind of analysis as well. So the other thing to mention is based off of that hands on hips posturing, that's our atrophy sign. So if someone does have like divoting in their infraspinatus area, you're obviously worried about this kind of an error palsy. And then same with like for this one here, if you're seeing like inferior border prominence, it's significant border prominence, you're thinking about the long thoracic nerve. Again, those are zebras, but definitely like can occur.
Yeah, so examples in your manual within the annotated bibliography would be shown like this, where there's just a little bit more to look at. And that's good, a little bit more to look at on these examples rather than on tree.
So it's not your ready for one.
Yeah.
Here.
All right, and then, so publication as of this year, in the physical, in PTJ, 2025, ruling out cervical spine contributions and shoulder pain, right? And the consensus of the experts that wrote the paper, subjective, your cervical spine should not be a component of every shoulder that you see. Right, it should be determined by a couple of things. One, your subjective screening questions, which I've listed the criteria here that would be required for further assessment of the cervical spine. And then Rob Weiner out of Texas gave us a classic predicting elements of what would be cervical radiculopathy. And even if it's not a true radiculopathy where you're having hard neurological symptoms, this cluster can still be a determining factor as to what the contribution is of the cervical spine in referring pain to the shoulder complex. And you're looking for what Maitland would call your concordant symptom. Is it the pain and the primary complaint that they're coming in with? I would love the opportunity to go through cervical spine, but we're gonna focus solely our efforts on the shoulder complex for the moment and for the remainder of the course. So the way that we've broken it out is you have step 3C, and then you have more pathoanatomical diagnosis workflows in 3D. Universal shoulder assessment. Everybody gets these assessments that you see here. And then you break it out into what is your primary leading differential diagnosis based off the subjective and the medical history that you've otherwise reviewed. And then we'll run through what would be a column. So this is, if we're thinking algorithmically, it's like, which column do I want to run? If you pick the wrong column, it's okay. You're just making sure and giving reassurance that these structures are not a contributing factor. And the more often that you think this way, the less you'll take a wrong turn in your assessment, I assure you. Okay, universal shoulder assessment, standing flexion, unilateral and bilateral, and then shoulder abduction. Okay, if painful arc or altered scapular kinematics are identified, approximately in a third of cases, then you would go into a scapular thoracic differential. So this is, so I'm big on numbers. It helps me, I have this long bias that my own human biology is inadequate and is subject to error. So I'm gonna just have you face the screen, maybe if you move up just a little bit, maybe 2 feet. And now I'm gonna just kneel down and get out of the way here. So, we'll call the acute shoulder your affected shoulder, right? So that is your right. We're gonna ask for you to go into unilateral, that is left shoulder flexion. And usually when I'm in clinic, I'm not using these terms. I'm saying, okay, I need you to, monkey see, monkey do. I'm gonna have you go feet together, stand up in your best possible posture. And then I'm gonna have you bring your arm up overhead. There's definitely the counter argument where people would say, well, you're putting constraints on the system and he's not actually moving like he otherwise may if you give him these instructions. I want to make sure that I'm consistent such that any deviations that I see from person to person is the nuance of those persons. So you're correct. I am putting on some constraints, but it allows me to have objectivity and consistency across not only this patient, but every other patient that I see. So I become more and more nuanced in picking up these subtle deviations. That is, again, a principle of Shirley Sarman as well. Pattern recognition. Okay. So Tree, as you were, I go unaffected arm first. And while he's coming up, even though I'm somewhat blind to it at the moment, feel free to shout out, we're looking for any altered movements within the glenohumeral as well as the scapulothoracic joint. So we'll have you bring it back down. Typically in clinic, I'm either going to use a wearable device or I'm going to actually use a goniometer to capture that flexion as he goes overhead. Once more, Tree. Give some nods. People like it. Yeah. I would say there's a little bit of elbow flexion, right? But he also dissociates his shoulder complex pretty well from his cervical spine. Great.
Mhm.
And then again, you would do that same thing other side for time. We won't. And then you go right into bilateral elevation. And then I go into abduction. So we'll go unilateral abduction with the left. Again, I go monkey see, monkey do. Once again, elbow straight, boom, and as high as you can. Right? A little bit more of a cervical tilt slightly at the end, and then back down. And you're looking at both concentrically and eccentrically how well they control the arm. The other thing that I typically see is that people are missing this cone of space up here, and they'll go into shoulder drift, as I call it, or flexion drift, where they go whoop, right? And they can't access this. And for my post-operative shoulders, I describe it as, this is good rehab, this is great rehab, of like, how can you get into that upper echelon of cone of space? You're nodding your head.
I have a couple of patients right now, we're trying to get that.
Yeah, it's hard without getting like abutment or additional symptoms at that end range at times. Yeah, we'll talk about that with a range of motion assessment. Okay, and hypothetically, maybe someone else knows it on themselves. Do we have altered scapular kinematics? I don't know if Tree's our best example, but we'll run with it. All right, and then JC, why don't you use the scapular assist and go from there? So hypothetically, he either has a painful arc or do you have a painful arc on the right side?
I feel like it's more tight as I get right here.
All right, we'll run with that.
Yeah.
Yep.
Cool. All right. So we'll do the first one, scapular assist, and then we'll do scapular reposition after that. So scapular assist, like I'll have them run through that single arm elevation. So go ahead and do that. Going up and then come on down. I would ask them like when he feels the symptoms. So it's more of looking for that painful arc. From there, I will hold the inferior border and the medial border is on like where my thumb is. My left hand will be on top of the spine, the scapula, and then as he raises on up, I'm using my thumb on the medial border to help with that upper rotation of the scapula. Then go and come back down. I'll have him do that a couple times. Go ahead. And I'll ask him like, do you feel any improvement here? Any improvement in that painful arc?
Yes.
Okay. So if, from there, then I'm like, okay, well, check the box for upward rotation. So therefore, when I look into my, intervention standpoint, I would make sure I work on upward rotation. From there, I also do, posterior tipping or scapular reposition. So, I would, rather than, kind of similar with like my hand position here, for upward rotation, I'm using more of like my right hand and assisting with upward rotation. For this one, I'm using more of my top hand and working on posterior tipping. And then I'll have him go ahead and raise his arm up. And I'll just follow along with this one and then go ahead and come back down. Try to stay a little bit, rather than, getting your shoulder range from like TL junction, let's try to keep that a little more stiff. So I usually just say, all right, brace the core. Now go ahead and go on up. Good. And then come on back down. How was that one?
Easier.
Easier? Which one was more which one was a little better? The first one or the second?
The first one.
The first one? Okay, so from there, then I can prioritize whether I look more for upward rotation. But still, like, because that did improve his arm elevation, I would also work on posterior tipping. And so we'll go on through that. Now, something to mention here is that just to go into like more of why this like painful arc occurs, is that what the abutment of tissue underneath the humerus and the acromion, there's typically on normal like in normal posture, like in anatomical posture, typically it's around 12 millimeters of space between the acromion and the top of the humerus, and then there's obviously tissue between the two. Regardless if you're raising your arm up, you're gonna have tissue abutment at the end. Now the question is like, when does that tissue, like the abutment, come on? So you have, if you are anteriorly tipped forward, then obviously that space decreases to, let's say, 9 millimeters or so. So therefore that tissue abutment becomes much earlier in that range of motion, which is like what kind of why that you feel that painful arc in a way. And obviously there's, humeral elevation that comes from maybe being deltoid dominant and so on. We'll go over that later. But that's really what your hands are doing, is creating more space underneath the acromion. Cool.
Thank you.
And again, feel free to, Chia, are you still okay to, model? All right. And if you can say no, that's okay too. Okay, any comments? Again, feel free to shout them out, raise of hands as we go. So I kind of listed it off of there in the manual. If 2 or more of these are positive, proceed with scapular evaluation algorithm, otherwise proceed with diagnostic workflow. So for the moment, we're gonna proceed with diagnostic workflow, and we're gonna kind of hone in on each one of these columns. So, right, there's over 170 different tests that have been described as far as being quote unquote special within the shoulder. We've all heard like the limitations there within. If any of them were really good, there probably wouldn't be 170 of them. And so when we went around the room, no one was like, oh yeah, I want to know about the psychometric properties of the special test of the shoulder. And I hear you, because it is a little bit dry. What I have done, as I alluded to, is like if you click on this, I've tried to put them all into a chart as far as the psychometric properties and what implications they would otherwise have. For those of you that are more visually oriented, I've also taken the liberty of graphing that out. So you have on the y-axis, you have the diagnostic accuracy, and then you have the different tests listed on the bottom. It's stratified from lowest sensitivity to highest sensitivity, and then the specificity is shown in blue. And then this was a relatively new concept for me, as well as diagnostic odds ratio. The nice thing about that is that it uses an equation of both sensitivity and specificity, and speaks about the diagnostic accuracy of your test, irrespective of the point prevalence of the condition in the cohort that you're actually testing. So when we look here, is that external rotation lag sign, right, would kind of take the cake when I've stratified them from relatively highest to lowest. So again, I want to just be sensitive to the fact that we've tried to be thorough yet simultaneously efficient in how we go through this, and why we're giving the rationale for the flow chart for each one of these diagnoses is backed by that the psychometric properties and the evidence, whilst disregarding some of the less potent tests from their accuracy standpoint. Simultaneously, the flow has been organized in what I hope to be two things. One, less provocative to most provocative, so you're not irritating the tissue beforehand, so you get a bunch of false positives. Additionally, in a sequential flow that makes logical sense as far as the person's motion in space. Okay, Treat, if you're okay with it, I'm gonna have you stand up. We're gonna face the other way, and we're gonna go through this. So I'm less standardized with my constraints as to his stance with these. We just kind of go through them. And not only are we looking for pain, no pain, we are looking for the specific type of distribution of pain, not only based off his concordant symptoms, but also on the structure that we're trying to implicate. So it's not just enough to know how to execute said tests, interpretation of the test, and why it's being imposed is also critically important to enhance the diagnostic accuracy there within. So the first one that we're going to do is mirrors. So you have two variations of mirrors. So the way I described in the patient. So if you're going to hold a can of soup, right, and then you're going to put it at your side as if you're going to pour it out, and then you're going to turn that can of soup inward like this. It's not just going to be pronation; it's also going to be internal rotation. And then I want you to raise that can of soup as high as you can. All right, so that's active mirrors. He doesn't want to go much higher, and I don't want to hurt you, but what I would do, I would say, okay, he doesn't get, I would ask, can you go higher? Yes. Any symptoms with that? Right. Yeah, so he gets a little bit of tightness, and then can you just do that comparison from side to side, come back down. If it's not clean, then I'm going to do it passively. Can you go ahead and go back into that position? And then I'm going to assist at the scapula, and then I'm going to be sensitive to tissue stress. And again, asking permission to go higher if I'm going to push beyond just the first resistance that I feel. And again, what are we looking for? We're looking to close down on subacromial space. We're looking for relatively specific symptomatology at the top and or potentially like referral pain into what is the shoulder patch. Not shoulder, but shoulder, right? As in, right? That is what they call this area. Yeah. Okay, great. And then you go full pan. So we're going to stick with our analogy of that can of soup. I'm going to be having in the scapular plane. So go ahead and elevate it to shoulder level. And then I'll just deviate slightly somewhere like that. Typically in clinic, I'm monitoring this with a make test with a handheld dynamometer so I can get some force output as far as the determination of forces and comparing that also side to side as well as against normative data. For here, in all intents and purposes, it'll be more of a provocation test rather than a quantification test. And then I'm just going to hold steady, Tree. I'm going to have you gradually push up into me and gradually ramp up your force as forcefully as you can. Once again, we're trying to implicate the superior aspect of the rotator cuff as he forcefully engages. Go ahead and relax. But really, that test is best diagnostic when you have it in combination of a comparison between that and your internal rotation, where you then lift up, empty can, again, push again. Any symptoms or provocation with that?
A little bit.
Yeah, so a little bit more, that would be a positive test. And where do you specifically feel it? Yeah, so pretty specific to the supraspinatus. That would be starting to get into our differential on this first column, which we're running through our shoulder impingement syndrome versus rotator cuff. We go then through your champagne toast test. So I don't know if you've ever toasted a room, but if you have, it would be something like this. So this is one of the most specific positions, and it's shown to be even better diagnostic accuracy in some studies compared to your empty can for supraspinatus. And so I'm just going to offer my pressure here and then hold strong, right? And then any issue. And then can you push up into me simultaneously? And once again, I would be looking at the force application there if we were in clinic. Yeah, and then relax. And so, yes, some supraspinatus subacromial pain symptoms, but he was okay with the toast test, reducing our the extent at which his supraspinatus may be involved. If there was more involvement, he may not be able to hold that. We go into our resisted external rotation. I encourage you to test throughout the range and then to buttress on the inside of the elbow. So go ahead and actively push out at me. And then when I'm going to relax, so your motion is going to be like this. Yeah, and then go ahead and I'll let you win as you push out into me. And so I'm getting a sense of his strength throughout the range rather than just an isometric in that one position. And then I'm making sure that he's not abducting by having that secondary buttress here. Again, handheld dynamometry is optional if you so choose. And then now hold strong, but let me simultaneously win. So you're looking at the contractile tissue under eccentric load, which is usually more of a provocative test, and that's why I start with the concentric. The next sequence really is not going to be applicable in Tree's instance because what we're looking for is a complete rupture or significant implication where you go through your pate sign and your drop sign, which is essentially they're essentially the same test, just at different degrees of abduction. So first is like this, right, where I go like this, and then he would potentially fall in, or I would offer resistance. The last one up there is horn blowers, where it's like this, and then hold strong. I would offer gentle progressive resistance at the back of the wrist. If they can't hold it, right, usually what they will do will, again, kind of horn blowers, that's how it gets its name, they will flex the elbow as a means of resistance. Not all people will go into that compensatory motion. So keep in mind that you're also just looking at force, a gross streaming of force, but it is more of like a provocation. You're really trying to determine whether the contractile tissue is intact or otherwise.
Michael, so for horn blowers, because biceps like secondary function is a shoulder flexor, that's why they like when they have a rotator cuff tear, they go into that function because the biceps is like overriding that function. So like that will help you kind of remember like within the biceps point for that test specifically.
You mean that the bicep compensating is?
Yeah, it's trying to help out for the fact that the rotator cuff is torn. Yeah. That's why usually like when you look at like pain location, they'll have pain like over the biceps tendon specifically. Too. Yeah.
Okay, and then the next sequence, again, kind of goes in what I think is kind of an ergonomic efficiency, a movement efficiency standpoint. So it goes Hawkins Kennedy, forecord impingement, Yokums, where you hide your eyes like this, and then lift off, where you're actually trying to lift them off, right? So Hawkins Kennedy, maybe everyone's pretty good on it. I'll try and make it so I can see. But what I typically see is that some clinicians will be like this, where I'm literally blocking myself with my elbow. Where I need to come is I prevent the shoulder from popping up with my one hand, and then I'm getting my right elbow out of the way so that I can internally rotate it. Right? Yeah, and usually if you do it correctly, it's uncomfortable. Right, but we're not just looking for discomfort, we're looking for a meaningful difference from side to side and a specific symptom. Forecord impingement, right, which is a different type of impingement that we'll actually describe it a little bit more medial, right, at the coracoid rather than up onto the subscapularis, or the subacromial space. And it's the same thing, but you just do it kind of in flexion. If you're suspicious and you wanted to screen out for your labrum, you could do your O'Brien's as he comes across his body, but right now we'll stick in this one algorithm. And then, so I say, I need you to go like this, again, monkey see, monkey do. So they typically do that, they typically go into cervical flexion. So, Tree, if you keep your height, yeah, there you go, yeah, perfect. Right, and then I'm into my algorithm for looking at my subscapularis at this time point, right? All those were my impingement tests, hold strong right there. I'm gonna try and lift you off, don't let me do so, right? Pretty good, awesome. Then we go kind of our Napoleon, hand on belly button, elbow flared, right? If they can do that, great. Then the next thing is gonna be our belly press test. Again, that's also been described with your handheld dynamometer if he puts it on his wrist. So you can determine that force, a positive test, they either go into they go into wrist flexion and or they'll abduct. If they have implications within this test itself, right, and just for a quick, so your belly press, I think it's number 67 that I have it. Right, so you can grade the stratification of where the extent of the disruption is and how much. So bear hug, right, which is this one, it implicates the upper third of the subscapularis and tears of greater than 30% in that region. Greater than 50% of your Napoleon, if the Napoleon is positive, greater than 50% of the tendon is implemented. The belly press, 30%. So obviously that's less because there's an active component. And then finally is the lift-off test in the back. Right, where if they can't do the lift-off test, that really is truly problematic. And then as far as like the greatest, statistically, the risk of having a greater implication if they just can't actively lift off. And then the final one that you see there is Gerber's test, where he can't do it. I lift him off and then he still flops back, right? He can't hold it. And then internal impingement we'll go through once we get people supine. Okay. So we're gonna pause there. You don't have to partner with the person at your table, but that would be convenient for pairing at the moment. So where are we gonna start? I'm just gonna ask that we start at running through 3C and then 3D as far as like the rotator cuff specifically. And we will set a timer for about 10 minutes. And so we're gonna break out with your partner, likely within 10 minutes. You probably can't go through the exam twice over. Maybe you guys, one of you is a physical therapist, one of you is a patient, and then halfway through you swap.
We're out of space.
Damn it.
So I got the first notification in the subjective portion, halfway through, so I just done the back half of that.
Yeah, okay.
And then I just missed the last test on that.
That was too. So dang it.
Got a lot of stuff. But
You know, called it not, yes.
we got a lot of content.
Okay.
Yeah, cool.
Probably. Okay.
Right.
Yeah. Yeah. Really? I don't know if you have any. For us, a little harder and a little bit. Yeah. Do we want, you go like that? I'm very. Straight. I was married to it. He didn't go. Right. 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 All right, regards to now. Yeah. We should go already. Yeah, so we're crashing positions. Introductions. But we know there's association of our science. How we get them. That order. And so, Actually, it's on most of the, was very shy. So, I feel like that turned it down, then when we got the range of the winds. Yeah.
That was so street.
The big one, but it goes like a book page. But, so that we came. One man or it's on. Now people like to check it, but if you go like a push it and go out, I'm down. Sure. We're going to have. That created needs. It's very conscious. Oh, city, yeah. Oh. I bet they the big property. Oh shit. I could always go back. Let's just be figure that out. Yeah. Well, it's just a child. Maybe if I get over my. Yeah. Or I may take that. Also, because I was so trying to say. So careful. You're doing the thing. Oh, yeah. Well, that's small. Yeah. Yeah. Okay, go ahead. And yeah. Anything else trying about me? Yeah. I'm thinking I was trying to help him. Yeah. How does that feel? Yeah. Don't know, we're ready to water, you can laugh. So find things or near, don't talk at me. How did that? I haven't looked at that. I tried, I just, I don't know. Oh, because you were over. Yeah. Oh. Okay. This is what you got. You're already talking. I saw. And the late road already done, probably other, although that's very, very neat to see. Oh, yeah, very much good. Yeah, it's all very good. Because. Right, yeah, so, yeah, keep going, probably go back, okay, yeah, I don't think that, you don't be snack. Partially, that's what, yeah. Or spiritually. Go ahead. It was fine, and, and that was all. Oh, I like the crash. That's gonna name. Every guy's good. Yeah. Yeah. Shouldn't be. No, it's so nice. Maybe busy out all the games. Hopefully, it was just sound. That. Here. This whole year, so you see. I didn't, and so they're gonna bring up that a lot of many things. Oh, you should sort of did. That's talking over, you know. I so. I think it's interesting. I don't make some. I could, you know, or either very good. That's what after that sounded maybe share. Yeah, very so by the boss. Then you don't want to know. I don't think about so nice. Like run. Or you get their practice. So they know it's taking the Yeah, that, that's the guy, I'll say it. But that one, the orange, she looks, it's gonna be it. They wanted the public school, the lunches and dinner, and it's basically on, and then happened. The lunch, you can't do it. You know, we just, they're one, I think yeah, yeah, so. Yeah. Oh, yeah, for this is to make sure that check on the doors. Can I do that? It doesn't check shoulder inflection here, and I go, well, we have to, yeah, there's no. I'm trying to get this. Yeah, and it's like, and it's a all. Which I can for I can I someone buying. Yeah, actually. So longer level competition. So that's why my big is going to do here and that is no longer. It's not all the movement, you feel the difference in force that. Oh, and so for me, like, I'm able to motion farmers after. For battle side. Actually, I was thought it had yeah. So you know, just walk there is Jimmy. This way, so you can constantly. That's what's talking about it's totally. So that is like yeah. So I would say, you know, in terms of treating the five, yeah, no, it's kind of like the notion yeah. I was gonna say, she found out the crack, but it was a crack. Well, I think we're there. Yeah. Right. Right. Yeah. Yes, yeah. Yes. What are the things? You're right. That's one of the reasons why I love it going. Yes. Oh, no, like that, relation to that, in the JC, that's our thing. Oh, I think I saw that. So, kind of, like that, everyone starts to. Also, where did you have? Yeah. 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 Yes. Yes, so, in this position, years, I'm getting a little bit of attention, right, stress. Just more, I discuss. I'm just, because when you get is, I'm like, that's where that works, like. So the job sold, they can move it, website and sheet, but. As I knew, things that were changed, like, I'm going to. Which is housing the. Exactly. Yeah, so that's gonna, I'm going to slow this. I would be there. It's just, I'll do something more sitting on it. Yeah, so my mom's. On the top of this, you like that, we come with awesome. We got awesome reference. The white dog was. And it's part of being right there, I was awesome. Did you show me this recording? Yeah, so it's just the opportunity. Yeah.
It's like, yeah, it's like,
Right here, it's easy. It's like, I'm seeing it up. Yeah, that's the one.
yeah,
That way, it's one. Yeah.
yeah, that's it. She said,
Short. Okay.
more speaker, a lot of, I'll add into the,
Yeah. It's pretty hard. It's pretty.
basically,
Tree, there's nothing, we all. Sport. It's just like. I saw it.
yeah.
Me, but text over the time, what's on? Okay. So you're here, you're not, very good at that should be something. So I was wondering, those, you're like options or.
I can watch that.
Yeah, it's really like.
She works is it's not like old or rest, man. I'm more working on, working in one thing, working at a time. And that's where I can't do a little bit more of work to do all this. So we have like.
And also thinking the rotation of the cage. Could it depend on, just.
Yeah.
Oh.
Yeah. 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 That's. Bring that here. Cool, awesome.
All right, guys, I think we'll wrap it up. For at least this breakout. Yeah, so then how do you want to play this? So options would be
Go
go
straight
in,
through, because like, we'll
roll
finish
through this.
those,
Yeah,
go lab breakout, and then we'll take a break. And then I normally need like 15, 20 minutes or anything. And that's like comfortable.
okay.
That's comfortable.
All right,
Like I'm not gonna rush. I think people are enjoying this. It's what they're like feedback all there. Yeah, I was that something like what?
Yeah.
To get bring on this. That's real at the moment.
Oh, okay.
That's how they get social.
Yeah.
I think she's okay.
Uh,
Oh. Bye.
Yeah.
So then we're gonna move into our standing instability or labral pathology is what we're gonna work through as we go through our next series of special tests and testing. So this individual, right, they probably have most likely they have some type of subluxation and or macrotraumatic type injuries. Not always the case, but oftentimes, at least in my clinical practices, that's what I'm seeing. And then they also may describe some form of like instability and or popping, clicking, or catching. And their symptoms may be still at that superior aspect, but it may come down more into your slap region. Very more often than not, it's going to be an anterior dislocation versus your posterior. Your posterior is only part of that. A very small percentage of what is a shoulder dislocation. So then label pathologies. So I need another volunteer. All right, Maheen, come on up. So perfect, thank you. And then we'll, again, feel free to get up, move about, and come closer. So we're going to start with a sulcus, load and shift. This has been described not only in standing, but you can also do it in supine where they may be a little bit more relaxed. And then we go through a posterior instability test as well. So he wants you to come on up. All right, any shoulder stuff that we need to? Okay, so typically what I'm gonna do is I'm gonna gently grasp around the condyles. Again, you can either come in the front and wrap around. Wherever, I think it depends a little bit on your patient and how your hand fits up relative to the circumference of their arm. For me, I feel like I get a pretty good grasp like this, and then I'm gonna gently palpate the front of the shoulder, and that is the glenohumeral head. And then I'm gonna gently traction. And pretty quickly, I won't do too much more than that, because I can already feel like it gaps. Right, and that's really what you're looking for. You're getting a sense of like how much force would be needed to potentially distract the joint. At time, this in itself isn't pathologic, but it gives you more information in regards to again, the collagen deposition and how stiff that tissue and that capsule may be. From the load and shift, I usually use kind of this more of a closed grip, almost like a mitten type hand. And then be just conscious of your fingertips as you compress over the anterior shoulder. Oftentimes people, because of the intimate relationship that the long-headed biceps has on the front of the labrum and front of the shoulder as a secondary stabilizer, typically this tissue is also involved in combination with the labrum. And then, so you can do a couple of things. You can either approximate the tissue to give a little bit more of a buffer, and then I'm gonna gently move it back and forth. Again, I don't need to push very hard on the heme to be able to feel the abutment right up against the rim, and particularly in both directions. So you can get a sense of how stable someone's gonna be anteriorly as well as posterior. I will say that this is one that I definitely needed to practice more than some of the other tests, because there is the nuance of like finger tension as well as just getting the feel of what is normal for the glenohumeral head. And again, it has been described in supine if you feel more comfortable, like you have better degrees of freedom there. And then with the, I guess I'm gonna jump down to the O'Brien's test, just for sake of time and for better diagnostic accuracy. We can talk about the other ones if you have questions during the breakout. But the O'Brien's test, so I'm gonna go back to my analogy of like a full can. You're gonna cross body like this, and then you're gonna ask them to dump it out. Once again, you'll do some resistance testing with the full can, and then also with the empty can as well. Okay, so as you work it, and then cross the body. And so there, I asked about symptoms. I then offer just a static restraint, and then ask Maheen to go ahead and push up into it. Any provocation of symptoms? Yes and no, a little bit, yeah. And then if we internally rotate, right? So once again, the brain doesn't like to put ourselves in the painful position, so just make sure that they do internally rotate, not just pronate, and then push back up into this, right? And then you're looking at the force differential between the full can and the empty can position, and then also the side to side in combination with the provocation. It should be noted that this is also listed under your AC joint pathology. So usually the AC joint will be more symptomatic with the full can versus the empty can. Typically, I've also subluxed my left shoulder too many times, and when the first time I did that, I was actually in PG school. I was like, oh, this is cool. Like, let me check it out, and the whole thing shifted. I got a big plump, and I was like, yep, that's good, right? And so test works, but you may all just be, that was sharing that personal anecdote is really neat. So like, go gentle, have them incrementally progress through it, because I had no sense of apprehension before it happened, and that would have been really uncomfortable if someone else said, if it was like outside of my own power, right, that someone else had done it. So those are the three that I think really need to be honed as far as the skill set here. To do those, and then we'll transition into our supine assessment, and we'll go through our apprehension, relocation, anterior drawer, and the biceps load as we go through those. Yeah, we'll do 5 minutes for this, and we'll wait for you. Then simultaneously at the end of this, we'll provide remaining as dirty off. Just get the table available for our next knowledge, you know, we're on the meters.
I learned a lot about building on myself. Right now, working for. I was. I have my shoes. And it's my team. Yeah, no, I will see that.
But then when you do your interior floor, I usually slow this is for something about it. No.
I used to. The old crowds. There's a big bird. And.
One possible fun.
Like that, yeah, you are to it. You do that, what she was.
Yeah.
Oh, I feel it. I, oh, wild. Okay, gonna be level. Okay, then the second one, what I'm saying. No, I'm sorry, oh, did you, I'll say that.
Everybody.
But weird, not that shit is fine.
Yeah.
Yeah. It's like everything. Now you want to play. Yeah.
So that's very good in tests. For me to do it on him, it is bad. That's sorry. So I usually stabilize the staff first. I find that. So the hard part is like, you kind of have to aim.
Okay, look.
This is a sure.
The young people.
It's only just a little bit of legal side where it's I love the flex. So I would advise. And this is all sides of me.
This is fun work. Yeah.
And that I really wasn't building.
Yeah. Yeah. Wow.
Yeah, and I see that.
Okay, there are. Yeah, that would be nice.
You know, it's not, you know, it is.
Yeah, I actually went out to the dance. Yeah. I actually, you're not.
No, I feel, I mean, my mind.
See, David,
I'll say county. Yes. I'm scared. It's not that straight up, but don't look on the wall.
Sarah, you said it was.
Right. Oh, it's fine.
I'm good. Sure. In it's education. You like
It's hard to.
they saw and then maybe now it's like yep now I go taking forward leave the shame. Well, you can talk yeah. Just the one thing.
Am I clear?
What's up? I mean, I don't mind it. Then it's the very young thing that really is like yeah. Yeah. It didn't. I think it's more in the override. 5 years minutes. And then the override is run. Oh, one while the television is just yeah, it's finishing. Right, and the rock, right, she the one going to put in. So you do I say you Thursday, do all that. Like one. Yeah.
Coming down.
Oh, this is.
Videos and we show.
Big.
She wants to do.
Who wants to upload?
I'm talking. It's right. Can see. That's.
Hey, I was telling him, we need a Best Buy after this, and then buy one. Yeah.
Like that.
Sure. Yeah, you can, we got, alright, so the problem is that the, tree planting was sure needs. Used to be thought of. Yeah, like AC are actually, I would rather than go really far. Yeah, but for the solar instabilities, I'm just sorry, I didn't start out stuff here. And then go, if it's negative, I will move that over class. Just, yes, yeah. Hey, yeah, you have a good comment here. Originally I think the O'Brien test was, stated like you go hands together like this, and you drop one down and go over, and then test there, and then flip it, and then like see if it's, like decreased chain. So I do tend to do that with someone like through our algorithm, they're like, you're really suspecting some ability to go off a laser check for like traumatic purposes. And they're not, like with the active range motion, not like, you know, trying to go through the provocation of like protecting. I will start here because it's a little less of like a provocative position and going all the way over here and take up all the pitches back out. If they're negative with this one, then I will move it over and then test them there and then go across. Because what you're doing is you're putting all the, like you're getting the end range tension, and then you will get that positive kind of like chain opener test for the superior return. Cool. Good, thank you.
All right, so we're gonna be up here at this front table, and we're gonna do a couple of supine assessments for both of these conditions. Just want to connect to the internet.
Oh, I got it.
All right, so we'll get another volunteer. Yeah. All right. For the supine assessment, we're just out of convenience of positioning, we're gonna take into account our internal impingement for our in our rotator cuff section impingement algorithm, and then we'll also incorporate then the labral pathologies as well. So there's a sequence of that. Do you have a shoulder preference? And then shoulder preference. No. I'm pretty particular about I guess, I don't know what's the best view of the people on the side to help. I think it's similar to what I was talking about with the constraints in standing. I do the constraints in the kneeling position as well, and I always reassess for any changing of symptoms with a change of position. So I always go knees back, feet flat. You want us to take our shoes off? No, okay, no, okay. And then, so then this just allows for this taking, obviously there's ethnicity differences as far as the amount of convexity and lordosis that people have within their spine. This just, for the vast majority of people, this allows their torso to lie better flat. And then it also allows thus the scapula to do the same, giving me a more consistent assessment of the glenohumeral, which is what we're looking at. So we're still in our rotator cuff pathology. The last one that we have here is a different type of impingement. This is our posterior impingement, where we get essentially on the subarticular side, the soft tissue, usually on the back side of the infraspinatus and supraspinatus common tendon, is that we get like a pinching within the joint. And typically, see it a lot in overhead throwing athletes. I actually have seen it more often than not as well with people that just have a relatively lateral ability, and they don't incorporate their scapula into their extension or retraction position. So that the step is remains stable, and then they're just like pivoting the glenohumeral head, or the humeral head on the glenoid as they go back into these positions. So the position is you're trying to, for better or worse, you're trying to implicate and reproduce the symptoms. And so you get this with your passive testing, but if you're gonna do it as an active test, I'm actually gonna drop her a little bit into the plane of the table rather than playing with the scapula, because that's gonna further have a greater propensity to pinch on the articular surface. And then I'm gonna passively go into my external rotation. And if indeed this is a positive test, they will often prescribe like a pinching or concordant symptom on the posterior aspect of their shoulder. What the other hand is doing, I honestly just did it out of habit, but I wasn't actually providing any force, is what you don't want to do is you don't want to provide an anterior to posterior glide of the humeral head, because that literally may be a position of relief to actually prevent the abutment, right? So if you're going for provocation, you want to be sensitive, but not on this, right? So that you can get the information that you're seeking. Let's actually spin you around. Let's go ahead here. I think that may be a little bit more available, just because that for anyone who can be able to see. Okay, so really JC will look at or take us through some muscle flexibility as well in this position. So for the time being, that's the end of our rotator cuff / shoulder impingement algorithm. And then we would go into this sitting positioning. We've already done our standing, you've done your O'Brien's, you're now into this secondary position. And what I do want to just highlight, and I'll pull it up just briefly, is with and it was brought up during our breakout, was with the load and shift test. So I said that it could also be done in a supine position, and it would look like this. The other, and again, you just can control the degrees of freedom. I think that there's less technical skill necessary for this. And at times I've gotten a better feel for it here. And then the other thing that's worth noting is that there's been some stratification, and you'll hear a lot of the surgeons and or docs talk about the grading of it, right? So no translation is 0, less than 50% of translation of the humeral head. And that, again, they've described a couple of different grading systems. So 0 through 4, graded with any grading system, the more levels of stratification, the more inconsistency there are, right? So there's also been the grade 1 and grade 2 to the glenoid rim or over the glenoid rim. So I did want to just come back to some of the commentary that was described during our breakout. But then this sequence goes, in my opinion, quite nicely from an efficiency of movement standpoint. So we go apprehension, relocation, and then anterior shift. So apprehension's pretty straightforward. Again, being kind to some extent and respectful. So I'm going to have my hand there, but I'm not really pressing. It's just really just more of a placeholder. And then as I bring her back into external rotation, if they're unstable, she may voice, or you can even ask or prompt, what is she feeling emotionally, as far as like whether she has any apprehensive of going into this position. The relocation would be like whether I push down, and then that would be a reduction in her symptoms. There's also the surprise test, where I would then quickly, I think it's okay in this instance, where I quickly lift off, right, which can re-elicit the symptoms, and because it's done in a relatively quick fashion, that may elicit more apprehension than just bring her into the position itself. The anterior
Mike,
drawer.
hold up for a second. So, real quick for those two, make sure that the arm is parallel to ground here. So if he goes up, like if he horizontally adducts here.
Show.
Yep.
So if he, like, if he comes up this way and does it, he might not get a positive test. So make sure it's actually down here when you do it, because what that's doing is opening up that anterior capsule. And so a lot of times what we do is like, like make sure that they're off the table so they're able to go down there.
And then the anterior drawer, right, I come with the three middle fingers and I come in from the backside. Again, I get them pretty close to their end range, just past their R1, maybe to their R2, depending on what the other tests have shown. And then I'm actually just kind of, it's almost like this. It's a little bit, it's a lumbrical grip and it's a little bit of a scoop with a little bit of stress to the anterior shoulder complex. Again, we're looking for potential shift and or apprehension that comes with that. I know this one's a little bit more difficult to see because my hand's like really underneath her. If I was to show on my own person, it would be like this. And then I'd be right at, I'd feel the glenoid rim and I'd just be quite as proximal to that as I can, but on the actual humeral head. Next one is, next sequence is all about trying to implicate the long head of the biceps pulling on the labrum. So you have biceps 1, biceps 2, you have crank, and you have passive distraction test. So biceps 1 is described at 90 degrees, and then I'm gonna actually, similar to what I did with G, I just orient them to the motion. So this is the motion that we're gonna be doing. And then I'm gonna have you actively try and bend your elbow. I'm gonna block all degrees of freedom, not only so that she doesn't drift down, she doesn't drift up. And then I'm gonna it's gonna be a make test as she gradually ramps up her pressure, right? And the harder she pulls with her bicep, the harder the long head of the biceps is gonna pull at the footprint and its continuity with the labrum, stressing the labrum, okay? Biceps 2, let me know if this is at all provocative. So you go from 90 to 120, you repeat it.
More possible is pain.
A pain and or again, similar to what I had described personally with the Standing O'Briens, is you may get a shift, you may get a clunk, you may get a click in combination with the symptoms. Yeah. The crank, so in one of my mentors, Dr. Michael Raymond at Duke University, he talks about, I'll never forget, the combing of the hair, because his children watched The Simpsons of like Marge. And he was like, if you ever had to like comb your hair if you were Marge, you do this, right? And that's forever sticks in my head in regards to the crank. So, so I'm gonna block a couple of, I'll just run on both sides. So I'm gonna come in, I'm gonna approximate, right? And that's gonna push the humeral head into the glenoid. And then I'm gonna comb my hair like I was Marge, usually in this case, and I will do it here. So I'm gonna have you scoot yourself up maybe 6 inches. So the crown of your head is equal with the head of the table. Because I do want to try and get into as much rotation as I possibly can. That's perfect, yeah. So, up, right? So I approximate and that shift comes more through my hips rather than it does through my arms. And so my hands can feel, because if they're busy adding compression, then I can't do it. And so I'm gonna bring her up to like R2, or maybe R1 into internal and external rotation. Yeah. Perfect. Final one, I gotta put your arm, give your arm back to you for a second. Passive distraction. I use the example, there's also an active distraction with this one, where you're gonna ask someone to turn a light bulb, right? So as you go into pronation and internal rotation, there's a big stretch on the biceps passively, and that pulls on its footprint, right? So you gotta go in the opposite direction. So I guess depends on your orientation, but for me, this is gonna be a counterclockwise movement with my right arm overhead. So in her case, right, I'm gonna bring her up, and you'll kind of get it as you do it. So if I go like this and I do it incorrectly, I'm like, oh man, I'm just like approximating the biceps. I want to be stretching it. So I'm always going to turn away from the midline And I'm gonna, again, it's not enough to do this, because that doesn't really tension the bicep. I need a lockout elbow, and then I need to go into my internal rotation. You can see the coupling of my hands to facilitate that. So I've got a locked into pronation, that's not moving, and then I go with my subsequent hand, my more proximal hand. And again, we're looking for provocation, clunk, clicking, something in that superior kind of slap region.
So are they testing the same thing, those
They are all testing the same thing.
load one, load two, is it just more intense? Why would you do all four?
Yeah, so similar to what I was describing in our standing sequence for a rotator cuff, we've tried to lay it out in a sequential fashion, not only from an ergonomic friendly standpoint, in this case, it kind of works that way, but really it's because it's a progressive load on the tissue, right? And so I don't want to start with my most provocative necessarily. I'm gonna just incrementally start to get a sensation of like, again, are you apprehensive? No, great, then I'm gonna stress that with my anterior shift, right? I mean, surprise or what have you, and then it's like, okay, you're not necessarily apprehensive, or you are, plus or minus, but then you're gonna go into a progressive loading demand, and the psychometric properties of the test also demonstrate this. With the higher overhead you get, the more specificity increases. That's fine.
I'm gonna try it.
Yeah, this will break it.
On the posterior,
What's that?
posterior.
Yeah, you want to show that? Yeah.
Also to that point too, all these tests are under like, typically we think they're provocative, but we also gotta think about like, if you're not worried about the labrum or the biceps tendon in general, then you can go a little bit farther along and do the ones that have the most like sensitivity tests. So that way you don't like, you check it off and you don't have to worry about that later. Cause that's also the point of going through all these tests is like, you're like, if you're not worried about the biceps tendon, like test it, make sure that. Like, so that way you don't have to worry about it later down the road. And let's say if it isn't a problem now, but they go through your rehab and then it becomes like an issue, come back and test it again and see like, oh wait, it came up to become an issue. So then that's like why your examination is kind of important in terms of like going through that graded scale as well. So I'm going to talk about the jerk and Kim test. I personally like doing this supine just because I feel like I have a little better like handle on the arm. This is more looking at the posterior inferior border of the labrum. The way I remember them, because they're gonna look very similar, is that the like J becomes before K. So the K, like so J is less provocative, the K one's way like more provocative, and you'll see kind of why. So what you're going to do is because you're testing the inferior portion of the labrum, you're gonna go into this external rotation position, but you're gonna start arm by side, and so this is for the jerk test. You're gonna add an axial load and you're going to move across with an axial load. Sorry. It's not a very comfortable test, as you can imagine. Now, with the Kim test, it's going to be same thing, but your hand's gonna actually provide the posterior and you're gonna add an axial. So it's axial plus a posterior load as I go across. That's one, yeah. So that's why I like to usually this one you definitely start with like the jerk before Kim.
Are you pushing down on the head? Where?
Yeah, so I'm pushing an axial load through the humerus to like through the humerus to the posterior portion of
Then
the.
what's that? Where was the underhand coming from?
I'm basically doing a posterior mobilization.
Okay, okay.
Of the humeral head.
Okay.
Feels like a scour test.
That's kind of what that's really what you're doing, but for the posterior inferior portion of the labrum.
How do you differentiate if somebody has some, OA and a humerus?
Sure.
How do you differentiate?
Yeah, it's a good question. So when you're thinking about someone like that's, I would categorize that within mobility deficits, likely, because they're probably gonna be in this like either painful or mobility deficit phase. So that's where the stratification for this type of testing probably wouldn't be as appropriate. Yeah.
And then also the demographic of your patient is also gonna be a dictator. So like, if I'm like 40 years of age and younger and I have a Fuchs injury, I'm more likely gonna tear my rotator, my labrum versus older than that, if mechanism of injury would be your rotator cuff, right? Just because the tissue changes over time with entropy. And then the second would be the older individual, the likely person that has osteoarthritis is gonna be in that older demographic. You know, depending on whether it's secondary or primary osteoarthritis, would, you know, they're usually 40 or post-traumatic or something of the like. And then for me, there's really nothing else in the shoulder that mimics the crepitus that you get with arthritis. And so I know I'm talking about that's like a creepy roll up, right? And you maybe more, yeah, and so it's I would recommend or think that you wouldn't make the mistake of misrepresenting crepitus for the click or the pain that you're gonna be getting with this test.
It makes sense too, if you're thinking about OA in the joint, you've got some changes in the cartilage too. I mean, you older shoulder, you're gonna have changes all around, the entropy we talked about, so.
Sure. All right, yeah, we'll break those out, supine test and we'll go from there. 10 minutes.
Yes, so, just be careful with each other.
Careful when you.
Stay.
Oh, yeah. No, that's fine, yeah. I mean, definitely gotta stress them out, like, yeah, we're just looking like the very beginning, it's.
That.
Yeah. Yeah. Oh, no, of course. Yeah, I mean,
They're doing this and it hurt, it's like. Shut it.
oh, right. That's how you start stratifying, like, why do you need to know this? I'm not, yeah, well, I'm not.
That's why it's nothing in the middle, a lot of conversation, all of us, we should be done with construction line.
But I believe this has been different, like, a few, like, up really, right? So that's like, but, sure,
And then the whole thing is pretty.
yeah.